Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from GlaxoSmithKline.
Hello, I'm Dr. John Ward, Director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health. I'm joined today by Dr. Stacy Truskin, Chief Medical Officer at the Mazzoni Center in Philadelphia. Welcome to this program titled Changing the Game in Hepatitis B Care, Breakthroughs and Advances to Optimize Patient Outcomes. Stacy, welcome. Please say hello.
Hi, it's good to see you. Thanks for having me.
It's great to be together again. So in this program, we'll navigate a series of key questions to highlight the importance of hepatitis B as a health threat for people in healthcare, to make sure they're getting vaccinated to prevent transmission, as well as they're getting screened to identify those already infected with hepatitis B virus so they can benefit from the treatments that are currently available and ones that are in development to be a part of therapeutic options in the future. So first, just to talk a little bit more about hepatitis B as a health threat. And globally, there's about 250 million people living with hepatitis B. It's a progressive liver disease that causes progressive liver damage, leading to liver cirrhosis and the development of liver cancer. Globally, hepatitis B is the most common cause of hepatocellular carcinoma, the third leading cause of cancer deaths globally. In the United States, there's some estimates that over 2 million people living with hepatitis B that need to be diagnosed and referred to care so that decisions regarding their therapy for those persons can be made. Recognizing the availability of a vaccine to prevent transmission, which has been recommended for the use among infants since 1982, there has been progressive increasing in coverage of vaccines for those younger age groups. Quickly, vaccine is targeted for those populations because young children have the greatest risk of remaining chronically infected once infected with hepatitis B. So a newborn that gets infected, 90% chance of remaining infected. For an infant, it's about 30 to 50% risk of remaining as a chronic infection. And then those children have a 1 in 4 risk of dying early from progressive liver disease and liver cancer if that infection is not diagnosed and therapies provided to them. So we have an opportunity to eliminate hepatitis B as a health threat globally and in the United States and other countries through making available vaccine, particularly for children, but also adults, as we'll touch on in a minute, and then getting screening put in place to identify those already infected. In the United States, the recommendations for screening includes that the screening should be made available at least once for all adults starting at age 18 so that that chronic infection can be identified. That screening has been modeled to show it's highly cost effective for the country. And we'll talk about the type of screening in a moment. It's very important to screen pregnant women for hepatitis B, that's HBsAg testing, to identify those that have active HBV infection and are at risk of transmitting that to their child, to increase the certainty of that newborn receiving a timely hepatitis B vaccination and other interventions to protect them from transmission. And then for adults, in addition to screening and vaccinating everyone, screening everyone routinely, really very important to continue to recognize the adults that are a risk for hepatitis B transmission because of sexual exposures and exposures in the workplace, such as healthcare workers, or to other blood and blood products, such as people who inject drugs. So, please think about, when was the last time you ordered a test for hepatitis B, and for what purpose? Was it for diagnosis? Was it to prepare someone for surgery or chemotherapy for cancer? Or was it moving now and beginning to adopt this routine screening recommendation that the CDC has put in place for the United States? And that's the direction we want to go in. We want to make hepatitis B screening a part of routine preventive services, like we screen for high blood pressure, or blood lipid counts, or colon and breast cancer, and hepatitis C screening. We want to make sure that adults are also getting hepatitis B screening. So, Stacy, please review the types of tests and what the results are telling us, please.
Absolutely. So you mentioned that the new CDC guidelines as of 2023 are really around this triple screening for everybody aged 18 or older, and then individuals that are at ongoing risk. And the triple screen is really around hepatitis B surface antigen, antibody to hepatitis B surface antigen, and then total antibody to hepatitis B core antigen. And there are some challenges with getting folks to be screened. And some of it revolves around stigma associated with hepatitis B. As somebody who works in a primary care setting, I know that we have a lot of competing priorities, sometimes a very short time to see our patients. And it's easy to forget to provide this really important screening. And I think the last piece around the barrier to implementing this screening is that they can be a little bit confusing to interpret, particularly to primary care providers who may not see positive tests very frequently. So just a quick moment to review what and how to interpret hepatitis B serologies. So if you have a positive surface antigen and a positive core antibody, irrespective of what that surface antibody says, it means that that individual has a current infection and should be evaluated for the appropriateness of treatment. And there's no need to vaccinate that individual because they've already been exposed and infected and have an active infection. If that hepatitis B surface antigen is negative and the core antibody is positive and the surface antibody is positive, that means there's prior infection present, but there's some immune control there. And what I would encourage every primary care provider to do is make sure on the problem list for the patient in their chart, you add a notation that there's a risk of hepatitis B reactivation with any immunosuppression or immunomodulation. We want to make sure that we educate patients and flag for other providers that that's present. If the surface antigen is negative and the core antibody is positive and the surface antibody is negative, then there's either a prior infection or they're in a window period, or there could be a false positive as well. And oftentimes in that case, it might be helpful to refer to a specialist for an evaluation. And there's some debate about whether or not vaccination is useful or not in that setting. And it probably is beyond the scope of a primary to figure that out, and can go ahead and refer to an expert colleague. If that surface antigen is negative and the core is negative, but that surface antibody is positive, that's great. That means that they are immune from a prior vaccination and they're protected for life. No further intervention is needed. If the triple screen is all negative, particularly that surface antibody, it means that they're susceptible. And that is an opportunity to vaccinate that patient unless there's some documentation that they've received their full vaccine series. And then you may want to re-examine that position. Okay. And then if that surface antigen is positive, but the core antibody and the surface antibody are both negative, that may be a false positive, but we want to make sure we repeat that screening panel in 30 days before a next hepatitis B virus vaccine is given. So that's a sense of how to do that. I would say there's no harm in keeping a table nearby you that allows you to interpret these serologies. Sometimes you have to reference a table like this a couple of times in order to really get it.
Thank you, Stacy. Those are all good points. So that screening review, stressing the importance of it, why it needs to be in place to identify a large number of people living with hepatitis B, many of whom are unaware of their status, the types of tests that are recommended, with the HBsAg test being the most important to identify those with current active HBV infection for whom treatment needs to be immediately considered. Now, let's turn to talking about a care cascade for hepatitis B. Let's start off with a discussion about the current treatments available and the benefit of current treatments for hepatitis B, but also recognizing some of their limitations.
Right. So we've already talked about the importance of screening individuals and the CDC's recommendation for that triple screen. And that really is the first step in the viral hepatitis care cascade or the care continuum, is really making sure that individuals are tested. That's the most important piece of this, and that they're aware of their status. If somebody is in fact infected with hepatitis B, that they're enrolled in care and that they're evaluated for the appropriateness of treatment. And of course, if they're not hepatitis B infected, that we make sure we're vaccinating appropriately, which we've already covered. And then you want to be able to retain those individuals in care. And the goal, of course, of treatment for hepatitis B is a functional cure. We want to make sure that we are doing our best to really remove that surface antigen if possible. So, John, to start off, the benefits and limitations of the current hepatitis B virus treatment landscape, if you could maybe touch on those.
Yeah, the benefits are that we do have readily available for many years drugs that are effective in suppressing viral replication, slowing the damage to the liver, and therefore limiting progression towards liver cirrhosis and liver cancer. Those medications are fairly easily given as far as one pill a day type of regimens, and multiple studies have shown that they will prevent about 50 to 60% of persons progressing toward cirrhosis, hepatocellular carcinoma, and mortality. So they clearly have a benefit. The limitations are that they are long-term therapies, if not lifelong, because most people do not lose their surface antigen or stop replicating the virus after the drug is stopped. And so it has to be more like an HIV type of therapeutic regimen where the drugs are given on a regular basis. In this case, for hepatitis B drugs, on a daily basis, and then monitoring to look at response. Also, currently, because of their long-term therapy, there's been long-standing approach to make this a fairly conservative death criteria for who would be benefiting from these drugs, and so there are people that are also recommended to be monitored over time to identify when that treatment would be benefiting for them. But there's been a real shift in the sort of the guiding principles for therapy and moving more from a conservative approach to recognizing the benefits of treatment and then supporting a more broader recommendations for who can benefit from therapy, coming from some of the studies showing the benefits of slowing viral replication before persons have severe liver damage. And this has really revealed itself most prominently recently with the WHO guidelines that were published last year. And Stacy, please discuss some of the high points that reflect this movement toward more expanded treatment criteria.
Yeah, I think that's exactly right, John, is that the World Health Organization's guidelines really have four areas of entry into treatment, all of which aim to lower the threshold for treatment. I think the American Association for the Study of Liver Disease and the European Association for the Study of Liver Disease have somewhat complex guidelines that require a relatively high viral load as well as a pretty significant transaminitis that set the threshold for treatment. And the World Health Organization's guidelines really do aim to lower both of those thresholds, simplify the approach to treatment to make it more inclusive, and also acknowledge that there are resource limited settings around the world that may not have access to viral load testing. And so it makes treatment accessible for individuals, irrespective if they have a PCR available to them as a technology. And so I think this is a real nod to understanding all of those benefits of hepatitis B treatment that you laid out in terms of reduced risk of developing hepatocellular carcinoma, reducing inflammation, and also potentially reducing the risk of transmission to others if you decrease the viral load. So I think that we are moving towards a space where the threshold for treatment will be simplified and much more inclusive.
So please think about, when was the last time you treated someone for hepatitis B? What were the circumstances? What were the reasons? And if you have not yet treated someone, as we share this information with you, please begin to think, how could I integrate this into my practice? How would I make this aware to my patients in a way that they could understand? Because we want to, make this testing and treatment as widely available as possible. And things that can be done automatically or routinely are the ones that tend to be more broadly accepted because they seek to minimize the workload on busy clinicians. One of those areas that can do that is around prompts through electronic medical records. And Stacy, I think you have some experience with that.
Yeah, I think again, working in busy primary care settings, really thinking about how we routinize routine opt out hepatitis B screening and hepatitis C screening and HIV screening, taking a pan viral approach is really important to be in alignment with CDC guidelines becomes just part of routine healthcare. So adding screening and linkage to how we approach care in a primary care setting is critical. The electronic medical record, as you mentioned, John, can be leveraged to take some of the decision making out of the medical provider's hands and to think about this as routinizing templates that we use, routinizing order sets. Some EMRs have pop ups or reminders for individuals who may not have had testing documented in their chart. So there are a bunch of different ways that the EMR can be leveraged to fully integrate CDC guidelines.
Another key strategy, just in my experience, is reflex testing in the laboratory. I know that clinicians don't have immediate uh, um, oversight of that, but multiple studies have shown, particularly more around hepatitis C, how that first test, in this case hepatitis B surface antigen, when that same specimen, once that surface antigen is identified, that same specimen can be used for the PCR testing to identify the level of viral load. So taking the load off the clinician of having to order or even see the patient again in the clinic, that testing can automatically be done, saving time and money. Looking ahead, some other testing is could well become part of this group of tests that will be helpful to identify patients that will be benefiting from treatment as well as monitoring their treatment. One of those is the quantitative hepatitis B surface antigen, where you actually measure the amount of surface antigen that's circulating in the system rather than just a yes/no result from a test. Studies are showing in the therapeutic um, options under study, the surface antigen level predicts the response to these new therapeutic agents, and so it can be very helpful in identifying the populations that will benefit from those treatment options once they are licensed by the FDA or the equivalent regulatory agency in the countries around the world. So the quantitative surface antigen will be very important to be aware of when those drugs are licensed, and those levels of quantitative surface antigen are set in those licensing agreements. So, in addition to the benefits of the current treatments, we're looking ahead to a new therapeutic era for hepatitis B with the therapeutic agents that are under study at the moment. And for those of you who have treated persons with hepatitis B, please think about when did you stop treatment for that patient? What were the reasons for stopping treatment? And what were the outcomes, of stopping treatment? I raise those questions to you now because we look ahead to a functional cure era for hepatitis B treatment that's seeking to overcome some of the limitations of current treatments, namely improving the treatment response with shorter treatment courses. So this is termed the targets. The targets for the new treatments is a functional cure, defined as a loss of hepatitis B surface antigen, no evidence of viral replication after a completion of a time-limited course of treatment. That is the functional cure we're seeking to achieve. And there are multiple drugs under development now. Stacy briefly outlined some of the different categories of these potential therapeutic options that will be becoming available to us in the next several years.
Absolutely. So there is a hotbed of activity happening in the space of investigational drugs for the treatment of chronic hepatitis B. So currently, there are drugs in a variety of classes that are being investigated for the treatment of chronic hepatitis B, and they include things like hepatitis B virus entry inhibitors, hepatitis B virus monoclonal antibodies, RNA interference, which are small interfering RNA targeted degradation of hepatitis B virus RNA, as well as targeted degradation of hepatitis B virus mRNA by antisense oligonucleotides. In that latter category, one agent in particular is in phase 3 clinical trials. And there's some promising data coming along with that drug. There are also drugs that act as capsid inhibitors. That's another mechanism of action that's being investigated. One agent in particular, morphothiadine, is in a phase 3 study out of China. There are hepatitis B surface antigen secretion inhibitors and direct acting cccDNA drugs. There are several toll-like receptor agonists. And lastly, there's an immune checkpoint inhibitors that are being looked at and other therapeutic vaccines. So as I mentioned, a lot going on in this space.
That's for certain. And it's really seeking to silence the virus, its replication, as well as strengthen the immune response to the chronic hepatitis B and relieve this immune exhaustion that happens because of the persistent viral replication. And it's really very exciting to see the potential new therapeutic options that's coming from this pursuit of a functional cure. Do you want to say anything more about this phase 2B study?
Yeah. I think I'll just mention quickly one of the more promising agents, bepirovirsen, that I mentioned, is in a study. It's the Be Clear phase 2B study. The results of that study, the primary outcome looked at hepatitis B surface antigen and hepatitis B virus DNA loss maintained for 24 weeks after discontinuation of treatment and absence of newly initiated antiviral treatment. And at 24 weeks, about 9 to 10% of the group 1 participants who received the drug for 24 weeks did experience a sustained surface antigen and hepatitis B virus DNA loss, with similar results in those receiving or not receiving nucleoside or nucleotide analog therapy. So promising there. It certainly will be interesting to see what later phase studies show.
Thank you. You also mentioned capsid assembly modulator agents. You want to comment on that as well?
Sure. So morphothiadine, we had mentioned that also as an option, and I think that study basically showed that the treatment with the agent was tolerated and had some antiviral activity in patients with chronic hepatitis B virus infection. So, we'll look to more studies there as well, but promising data to start.
Yeah, absolutely. Thank you. I think we've given you a glimpse of the potential improvements in therapeutic options for hepatitis B. For me, there's clear benefits of someone knowing their status now so they can benefit from current treatments. But it's also very important for people to be diagnosed and in care so that they can benefit from these new therapeutic options that are in development and should be available for clinical use in the next 1 to 2 years. So I see it's a very exciting time for hepatitis B. We're really at a transformational moment for hepatitis B care and treatment, but it starts with routine screening, identification of people with hepatitis B so that they can get care they need with the current treatments and be in care to benefit from the treatments to come. Stacy, please give me your sort of closing perspectives on where we are.
Sure. So I think that this translates in a very meaningful way for primary care practices, given the fact that there are robust treatments, new treatments, and all of these different categories of action. It's important for primary care providers to really heed CDC guidelines and implement routine opt out screening with the triple screen for hepatitis B. It's important for us to know the status of our patients, prevent it with vaccine, prevent infection with vaccine where we can. And if somebody is infected with the good treatments that we have available and the new treatments that are likely coming down the pike, it's critical to know who's infected so that we can begin to think about whether or not they should be treated. And I think the fact that treatment thresholds are evolving to be lowered and that more folks are going to benefit from treatment and treatment will be recommended for more individuals, it's a critical time to start integrating some of this work into our clinical practices.
Absolutely. I think the whole thrust now, including from professional associations such as the American Association for Study of Liver Diseases, how can we simplify screening and care to make this a primary care managed disease? Having said that, I know primary care clinicians are extremely busy, so that simplification is the key objective here, and working together, getting good feedback from primary care clinicians about what's working, what's not working, what could be helpful for them, will help us with the operational research that can help improve access to screening and the current treatments, as well as to make available the new treatments as they become licensed. Stacy, I want to thank you very much for this great discussion. Always a pleasure to be with you. And thank you all for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation. I look forward to all of you becoming more routine providers of hepatitis B screening, care, and treatment. Thank you.